So today we are going to deal with the shock syndrome, the circulatory disorders, or another name, hypoperfusion syndrome. The shock or the circulatory disorder usually is defined as a physiological state when we do have a significant system reduction in the tissue perfusion, and the consequence be a decreased tissue oxygenation delivery and an insufficient removal of the cellular metabolic product, resulting in tissue injury. So if you cannot take enough oxygen, enough nutrient to the periphery, this is one thing. And another one, the end product, the metabolic product that produced by the cells, it cannot be removed. So this toxic waste can kill the cells, can damage the cells, and that again can be a problem. Now, based on this one, what we have to do, we have to have a normal perfusion. What do we have to have for a normal perfusion? We have to have enough oxygen in the blood. The oxygen content of the blood, of course, is going to be dependent on a lot of things. We have to have enough glucose and other nutrients for the cells. And of course, delivery, this should be pumped, this should be delivered, and the carbon dioxide elimination. And this perfusion needs at least three different things. First of all, we have to have a normal pump function, a normal heart function. Next one, we have to have an adequate transport medium, such as a blood, and the blood should contain enough hemoglobin that can bind, first of all, the oxygen and can help to remove the carbon dioxide from periphery. And of course, the vessels, the tube system should be intact. It cannot be leaked out. So whatever is coming from the heart, it should reach to the periphery and should come back. And another thing, this hemoglobin, when coming back, the venous side should be oxygenated, should be refilled with oxygen, and should exhale the carbon dioxide. So should eliminate the waste product and should be, fill up with the normal oxygenation. Now, if you do have a problem with the circulation, with this perfusion, that can be a short happening, such as a syncope, orthostatic collapse, carotid hyperesthesia, electric shock, spinal cord injury, and so on and so on. But can be a long term that those sequence even relatively leading to a fatal death, and that is called the shock syndrome. So this is what will happen in shock. First, we do have an initiation phase, and this phase could be maintained for a long time, but after a while, there is no turning back, and that's be irreversible. So this is the stages of the classic shock. First of all, as mentioned, at the beginning, we do have a compensated one. The body is able to compensate and maintain tissue perfusion. Now, this situation, what's going on during this compensatory phase, it leads to the progression. Body begins to lose its ability to compensate, and finally, inadequate perfusion begins. And this inadequate perfusion leads to the irreversible phase, where cell and tissue damage happening and results in multi-system organ failure, and this is what leads to the death. Now, on this one, if you look at this graph, the oxygen delivery or the demand, the first phase, when we do have, that's a compensated. Now the next one, that's a decompensated phase. At the beginning, when we do have, let's see, the subacute and irreversible one, or reversible one, reversible one, that if you act right away and if you treat the patient relatively, they can go back to the normal situation and survive the shock. Another one, the irreversible. the patient, by the treatment, is will respond. But after a while, you can do whatever you like, but that's be irreversible. And another one for sure, the acute irreversible, as a continuation of this decompensation, leads to the death very soon. Now, these are the different stages based on the pathophysiologic event. First of all, we do have some reason why somehow the perfusion is altered, the low cardiac output or vasodilation, and that can be compensated. And because the decreased perfusion, the major end organ perfusion or the dysfunction is happening, and is still potentially reversible. But the patient starts to develop decompensated stage. And when the microcirculatory failure and endothelial damage occurs, now that can be the initiation of the irreversible phase. And when after the cellular membrane injury and cell death happening, now that's be the completely irreversible shock situation. Now, what kind of markers we can use to monitor the shock? First of all, we can look at the systolic pressure. Usually the systolic pressure is less than 110 millimercury. Tachycardia occurs, the heart beats usually is over 90 beats per minute. Shock index, as I mentioned before, that the pulse divided by the systolic pressure, it should be equal or over 1. The respiratory rate can be low or can be high depending on the stage or depending on the cause. Urine output usually is very low. The metabolic acidemia happening. All the time in shock, we do have a metabolic acidosis, meaning that the actual bicarbonate level is going to decrease and the base excess be negative. So the base deficit, this means the base excess is negative. Hypoxemia, but the hypoxemia, or it's depending on the age, relatively, if the age is between 0 to 50, you have to consider as the oxygenation of the partial pressure of the oxygen should be less than 90 millimercury, but elderly one less than 80, and it's an old one less than 70 millimercury. And the continuous vasoconstriction, the peripheral vasoconstriction, and vasodilation can happen depending on the type of the shock. Mental changes. Usually this patient is anxious, agitated, or indifferent, so lethargy, obtudation, depending on the phase of the shock. Now let's see the classification of the shock. So what can lead, what is the initial problem that leading to the irreversible shock syndrome? First of all, the most commonly evaluated and mostly researched shock type, that's a hypovolemic shock. The classic shock is a very common one, is the standard used to compare other forms of shock for differential diagnosing. The hypovolemic shock, basically we are losing the blood, losing the fluid. And that can be the hemorrhagic shock, that's a blood loss, but can be caused by dehydration when we're losing fluid. And because we don't have enough feeling for the fluid, we cannot, maintain the normal circulation. The obstructive shock, that can be due to the obstructing the vessel somehow, so the blood flow is stopped, such as the pulmonary embolization. When it's happening, this stop in the pulmonary circulation, it has to be a big artery that is usually blocked. But for example, pneumothorax tension or increased intrathoracic pressure can alter the circulation in the lung. Or cardiac tamponade, or there's a pressure in the myocardium and decrease the preload, for example. It can be cardiogenic shock when the pump function of the heart is failing. Usually 40% of the myocardial damage is due to acute myocardial MI, but mostly due to arrhythmias, for example, ventricular fibrillation. Another one, it's interesting one, that's the distributive shock. In distributive shock, there are at least 3 different categories, such as a neurogenic shock, when we do not have a normal neuronal tone maintained of the vascular resistance. So we do have a vasodilation due to the, let's say, the failure of the sympathetic stimulation, anaphylaxia or anaphylactic shock, when we do have a vasodilation due to the EGE-mediated degranulation of the mastocytes or histamine liberation, and that is going to cause vasodilation and clot formation and bronchospasm, so a respiration plus the peripheral perfusion be abnormal. And the septic usually is the combination of this all: vasodilation, fluid shifting due to the overwhelming infection, and heart deterioration, so and the bacterial infection. So that's leading very fast to the final stage of shock. Now, let's see the different stages of this hemorrhagic shock. Let's see the first one, when we do have the compensation is working on. When we do have a volume depletion, as we listed before, the body is going to detect that something happened with the blood pressure or something happened with the volume, and because the cardiac output starts to decrease, that will increase the sympathetic nervous system and releasing epinephrine, norepinephrine, to stimulate the alpha and the beta receptors. What will happen? Vasoconstriction, usually in the periphery. So this is why the cold extremities, for example, is the hallmark of this situation. And bronchodilation and tachycardia can develop due to the release of the sympathetic stimulation. What will happen? The neuronal and immediate response occurs, and that initiates the sympathetic system. If, for example, the preload decreases, the low pressure receptors is firing, and these low pressure receptors is located in the arterial wall and the pulmonary arteries and the great veins and the ventricles. Another one, when the cardiac output decreases, the high pressure receptors sensing it, but it's located in the aortic arch and the carotid sinus. And the chemoreceptors usually turning on when the mean artery pressure decreases below 50 millimercury. And these receptors, chemoreceptors, located in the carotid and the aortic bodies. If it decreases further, if it decreases, the VAP decreases below 40, then the central nervous system ischemic response turning on. So we do have a massive sympathetic innervation and stimulation to the body, such as we happening a vasoconstriction, those vessels that sensitive to this one, such as the kidney, splanchnic area, muscle, and adipocytes, and adipose tissues. Beta 1 receptor, for example, the heart, that stimulates the heart rate and increases the cardiac output, but a lot of energy needed, because if you want to increase the cardiac output but increasing the heart rate, that takes up a lot of energy and decreases the diastolic time. So it meaning that the coronary circulation is altered. And the B2 receptor usually alters the metabolism. For example, mobilize glucose, induces lipolysis. This one will happen. And the other one, intrinsic or intermediate response, this usually happening a little bit later on. So for example, when the capillary pressure decreases, the interstitial fluid goes back to the vasculature, and that means in the first hour we can have about 1 liter transfusion, an autoperfusion that maintains the vascular, let's see, fluid level, but its maximum 2 liters can come back from the interstitial spaces. When we do have hyperglycemia and the osmotic effect is sucking the water with it in the vasculature, and usually that can give you, well, not too much, about 70 milliliter per 1 millimole per glucose, so it's almost nothing. Later on, the humoral response turn on, but that's a delayed response. Usually it occurs within days when the ADH secretion turn on. This is why the patient feeling thirsty and wants to conserve the water and produces more concentrated urine. Aldosterone. That aldosterone, renin-angiotensin aldosterone system, first of all increases the blood pressure, the peripheral vasoconstriction, plus induces the sodium reabsorption, and the water comes with the sodium. What will be the consequence of this one? At the beginning, we do have a normal cerebral and cardiac circulation until the systolic pressure is 70 to 90. But this circulation is usually maintained by the peripheral vasoconstriction. This is why the peripheral pressure or peripheral resistance increases. The patient will have skin pale and kidney less blood supply, so decreases the diuresis, so the urine volume decreases, and the muscle gets less oxygen, less nutrient, so weakness. That's be the general symptom. In a progressive phase, when we mentioned that the vasopressin ADH, which increases the vasoconstriction by closing the capillary sphincters, greatly reducing the peripheral circulation, and that's a hypoperfusion. It will cause some accumulation of the metabolic waste products in the periphery. In a normal metabolic system, when we do have an aerobic system, we do not have too much waste product accumulation. Mostly carbon dioxide, that's be the end product, and carbon dioxide can be removed through a periphery very easily because it's diffusing out almost readily. However, if you do have an anaerobic condition, the lactic acid accumulation can occur, and of course the lactate production is not associated with very good ATP production because the efficacy of the energy production is very low in anaerobic condition. Now, and this can lead to relatively the irreversible stage. What can be the mechanism? The compensatoric mechanism that maintains the normal circulation is going to fail. So what will happen? In the periphery, we do have a lot of acid production. And the acid is going to open up the sphincters. So it's going to cause vasodilation in the periphery and vasoconstriction in the lung. Microembolization that happens due to the stasis, what's happening in the periphery, and other waste product that gets into the circulation. So whatever accumulated in the periphery and so far was locked out, now due to this vasodilation, general vasodilation, the old waste product is washed back to the systemic circulation and can deteriorate some other organ, such as heart, such as brain, such as lung. And this means the cell damage and organ failure develops and the death occurs. So this is the irreversible stage, and these are the mechanism for this one. Now, the distributive shock. This is another type that we discussed, and that's relative with the vasodilative situation. As we mentioned before, the neurogenic one usually happening when the spinal cord injury occurs, or when you overdose the drug or poisons affecting the sympathetic nervous system, and that cannot maintain the normal vascular tone and leads to vasodilation. Anaphylaxia. If something triggers the anaphylaxia, again, a massive vasodilation and the fluid shift from the capillary to the cells or the interstitial media. And that's lead to the microclotting mechanism that can cause disseminated intravascular coagulation and smooth muscle contraction in the lung, so bronchospasm can happen. And the septic one is what we are going to talk about. The vasodilation and fluid shift is due to the overwhelming infection and perfusion. The distributive shock, if you want to summarize what are the different categories of distributive shock. First of all, the patient has a normal blood volume. They do have a normal tension. And decreased total peripheral resistance due to the general vasodilation. So how can we maintain, let's say, the normal tension? Well, increased cardiac output. So it means this patient has a tachycardia. So the cardiac output increases about 2 to 3-fold. What will happen? Because the periphery we do have vasodilation, usually the extremities are warm and red, and for sure, as I mentioned, the heart rate is increased. Now, what will happen in the hyperdynamic stage? First of all, we do have the accumulation of lactic acid because there is no time. It's not enough to take the fluid to the periphery, but you have to have enough contact time to let, let's say, the waste product to absorb and the oxygen diffuse in. If there's a, let's say, the velocity is very fast, the contact time is very short, again, we do not have a normal perfusion in the periphery. And what will happen? The changes in amino acid metabolism, the tyrosine and octopamine that inhibits the alpha receptors, and further vasodilation occurs. Usually, for example, in septic shock or any situation, we do have an increased nitric oxide production, such as cytokine-induced or endotoxin-induced, INOS, the inducible nitric oxide synthase activity, so more NO production. And as I mentioned, relative oxygen deficit in the periphery due to the abnormal, let's see, diffusion that's happening in the periphery due to the low contact time. The anaphylactic shock, usually they sensitize the individual, the patient, exposed to the antigen that trigger the EG-mediated activation of the muscles. And what will happen? Relatively vasodilation again, or decreased sympathetic innervation of the vasculature, for example, drugs, foods, white nuts or seafood can initiate this anaphylactic reaction. Direct smooth muscle cell relaxation due to the endotoxin or endotoxin-induced cytokine release. Now, the septic shock is a multiple initiation or multiple pathomechanism. First of all, we do have a direct tissue damage, and the tissue damage can be sterile. It still will induce inflammation, hemorrhage that leads to hypovolemia, that leads to hypoxia, tissue injury, again inflammation is turned on. Infection, the bacteria that's going to cause inflammation and sepsis. And this is going in trauma that's going to happen the all. This is why in trauma that's the septic shock develops mostly, and that's very, very dangerous situation.